Hi, my name is Jared Troutman. I'm the Medical Director for UMC EMS and Lubbock Fire Rescue. And today we're going to talk about the surgical airway procedure. We're going to cover some of the indications. We're going to look at the kit that we use here with our pre-hospital service. And then going to use our mannequin here and actually perform the procedure. So the surgical airway, probably the most invasive procedure that paramedics will do, and one of the more invasive procedures that I would even do as an emergency physician. So currently, when do we do this? So when we think about the approach to the airway, typically we think of our basic type stuff, our BBM, our jaw thrust maneuver, and then we kind of move into intubation, doing RSI and such, and most of the time that gets our airway secured. But we're all going to run into a difficult airway, and if you haven't yet, you just haven't been doing this long enough. So give it time and you'll get there where you have a difficult airway. Now, fortunately, we have lots of adjuncts to help us get these airways. Some of the common ones we use here is some kind of blind insertion device, which we use the King airway here. And then we also have a King Vision, which is just a video scope to allow us to have better opportunity at securing that airway. And then we also have a bougie. So when we approach that airway, if we usually say 2 attempts by the same provider, we can then allow a 3rd attempt by another licensed provider. I like to say spread the wealth. Even if you're the most experienced person, you've been doing this 20 years, and you have a newer guy there, if he's an intermediate or paramedic and is adequate to do this in his skill set, let him get a try. Sometimes there'll be something that they may do a little bit different. They'll get the airway. But now, if they don't get that airway, now you've tried several times, what do you do next? Next thing is continue your basic skills, BBM, maybe a bite block, head thrust, see how our oxygenation's doing. If our oxygen's still doing okay, if we can get them to back up, then let's go to maybe the King airway or the King Vision, or attempting to use a bougie. If you still cannot get any of those devices to work and you still cannot get that airway secured, now we can start thinking, does this patient need a surgical airway or not? So again, we want to look at, are we able to bag the patient? If we can bag them and their sats are in the 90s, I probably wouldn't do the surgical airway in the field. I would get to the hospital, let one of the physicians try. Sometimes we get the anesthesiologist or get some kind of additional, like a bronchoscope, to try to get the airway. But sometimes you got to bite the bullet and do the surgical airway. If you can't get the patient bagged, if the stats just will not get above 90, then it's time to do the surgical airway. So we're going to go over that now. Hi, alright, so we've been talking about surgical airway today, and we've got a new kit that we're using here. So we're going to go over all the details of what's in this kit, and then we'll look at how we actually utilize it. So the kit actually comes in this kind of just a black bag. It's really sort of unmarked, just has an expiration date on it. So we've already opened the kit here. Several things we're going to find in here. One is a mask and face shield. Do we just throw that away, right? No, you really should use this. Surgical airway can be a very bloody procedure, and we want to protect ourselves first. So I would highly recommend placing that on. Next device here, we're going to have a blade, so we have to do some cutting here, so that'll be in this kit. We have a little chlorhexidine wipe, because this is a semi-sterile procedure, sterile as possible, so we'll use that for that. Going to have just a 10 cc syringe that we can end up placing air into our endotracheal balloon. Just got a few gauze sponges for you. This is just a standard, they actually have a 6.5 tube. A lot of times they'll recommend 6.0s. This comes with a 6.5, that's fine. But do remember, usually about a 6.5 is probably the largest you could use. but there's absolutely nothing wrong. If you get to the point where you can't get that tube in, grab a normal 5.5, 6.0 off the shelf. This is just a standard endotracheal tube. The tube holder that this set comes with, we looked at this pretty closely. Everybody's familiar with the regular tube holder that we use, and this is essentially identical to that. The strap is a little bit different. Our other straps are like a rubber, and this is just more of a felt. So this, everybody should be familiar with how to use this tube tamer, tube holder. Kit also comes with a trach hook. It's in a little different packaging, and when you pull it out, you know, it's just a little kind of black cover, and you'll pull that off, and it's a little difficult to come off, but there to come off. And if you look there, it actually has a little point to it, so you want to be careful with that instrument because it can poke you, and we don't want to get poked. And then the last piece of equipment, probably the most important after the blade, is this, which I just call like a tracheal spreader. I'm sure it's got a more technical name, like a reverse hemostat. It's closed, but when you push it, it opens. So this will end up going down into our surgical site, and when we squeeze it, it'll spread open to give us better visualization. So those are all the equipment in our kit. So next we're going to look at how to actually perform the procedure. Alright, hi everyone, we're here with Mr. Jones. Unfortunately, he was involved in a bad trauma accident today. I've tried to intubate him twice, just due to his level of consciousness. I've had one of our other paramedics have tried to intubate. We've been unable to get the tube. We tried placing the King Aiway, tried looking with the King Vision. We just cannot get him to oxygenate. We started using the BVM. We got his stats up to 95, but now his stats are down in the 70s, so we're going to proceed with the surgical airway. Alright, we are currently zoomed in on the neck of our patient here. We've had a failed intubation, our sats are low, so we've made the decision to do a surgical airway. So the first step we're going to do, I'm going to palpate here on his neck. I'm going to look for his thyroid membrane, which I feel there. Right below that I feel a notch, that's the cricothyroid membrane. And then right below that I feel the cricoid cartilage. So I feel my landmarks there. So I'm going to get some sort of antiseptic. Our kits come with this little chlorhexidine wipe. You can utilize that if you have the chlorhexidine, the little wands. That's fine to use as well. So we're going to make our wipes there. So now we are semi-sterile. You know, this is not a completely sterile procedure. This is a life-saving procedure. So again, I'm palpating my thyroid membrane, my cricoid membrane, and I feel the spot right in between that. I'm going to go right in the midline with my knife. And I'm going to poke straight down in. Okay, so I'm just going to make a poke straight through, and then I'm just going to cut each way, make about a 1 inch or so incision. Okay, now we have our incision made in our neck, so I'm going to grab these reverse hemostats. I'm going to place them down into this area. Okay, then as I spread them, I'm going to look down and I can actually see my cricothyroid membrane. I'm now going to take my knife again. I'm going to come down into the cricothyroid membrane and I'm going to poke through it. Now I'm into the trachea. I'm going to now cut a little horizontal slit each direction, just about a centimeter or so in size. I'm going to now remove my knife. I now will take my tracheal hook and I'll try to go down through that incision I made, and I've got my tracheal hook down in there, and then I can usually insert the reverse hemostats a little deeper in, and now I can look down and I actually can see that I'm down into the trachea. If you have a partner with you, you can have somebody just kind of hold some steady pressure on that to help pull the trachea up and help keep it up in view. So now we have our partner with the trach hook, and I've got my reverse hemostats. I'm looking down in, I can see my trachea. You would take your 6 or 6.5 tube. Now I think in this mannequin, I'm not going to get my tube to feed. That's probably as far as it'll go, just because of the rigidness. But we're going to pretend like our balloon's down in, and remember, you just barely need that balloon to disappear. You're not going to put this thing into 22 or so. You're just probably going to insert it probably somewhere down here about where my fingers are, and I'll remove that. That's all the further, because you got to think when you're down in, that's about as far as that tube needs to go in. So you don't want it in like a normal tube. You got to think where this is coming out versus if it was coming out at the mouth. So once it's in place, you would then use the tube tamer we use to hold it into place. Alright, I hope you've enjoyed our video today on doing the surgical airway. Just a few statements about this is, first of all, if you have any questions or anything that comes up, feel free to talk to one of your FTOs or training chief or myself. Be happy to answer those. Also, if you want some bedside teaching with this, we can certainly bring you into the station and look at actually performing this and going through step by step on one of the mannequins that we have available. One question that's already came up was, Doc, we've always been taught to use a needle first and then convert to a surgical airway or make an incision. And that procedure's not wrong. It's not really the most common procedure. I know that's been taught a lot just in this area. I think it's an appropriate procedure. We haven't really encouraged that, if you will, because the needles we use now, as you're well aware, all the needles for IVs and such are all self-retracting, retracting needles. You really can't hook a syringe to it to see if you have that nice rush of air. So it's essentially we just don't have that equipment available. So I tend to think it's completely appropriate to just do that initial stab incision like we talked down in the trachea and then open from there. So if you have any questions, again, holler at us, and we look forward to doing the next video. Thank you.